Now request Ravindra Kute sir to kindly address the gathering.
Good evening. IMA Chandrapur branch has organized webinar on palliative care in non-cancer illnesses. And our esteemed speakers for today's webinar, Dr. Bhagyasri Barlinge Madam from USA, Padma Shri Dr. Raj Gopala from Trivandrum. Actually, this is very good topic for discussion. And I congratulate President Dr. Amal Poddar, Secretary Dr. Nagina Naidu Madam, Treasurer Dr. Amit Dewaikar, our Secretary Dr. Santosh Kadam, Treasurer Dr. Raju Agarwal, and our Senior Leader, MMC Executive Member, Dr. Mangesh Zigolode, all have joined today's webinar. This is a great initiative by IMA Chandrapur branch, and this will be the first seminar or webinar of our tenure. My sincere and best wishes for this webinar. Thank you very much.
So as you know, the title of today's webinar is Palliative Care in Non-Cancer Illness. Palliative care, what is it and why we have to do it and who is going to deliver it? What are non-cancer illnesses and do we really need it? What is our duty as physicians then? Let us talk about all this. So as we all know, the meaning of word palliative is to improve the quality of. According to the Merriam-Webster dictionary, it means to reduce the violence of a disease or to ease symptoms without curing the underlying disease. It is derived from the Latin root to palliare. It means to cloak. As we all practice Western healthcare, we know it firsthand that it is aimed at investigating, diagnosing, prolonging life, and curing. We all take pride in accomplishing each of these tasks. This way of thinking does not ask us to look into the quality of life or the suffering or the ultimate endpoint, death. So we avoid talking about death, but some people were brave enough to think about health-related suffering, death, and dying. The first one is a great person named Dame Cicely Saunders. You must have heard her name. She's from Great Britain. And the second one is Dr. Balfour Mount from Canada. The thoughts and teachings of Hippocrates should always be at the background of our conscience. Hippocrates taught us two important principles: do no harm. We all know that. It is the part of Hippocratic oath, do no harm. And the second one is a corollary of this: do not limit life willfully. In my opinion, not educating patient or the family about a particular disease or letting a patient undergo an unnecessary procedure is harming a patient. If we follow the principle of not doing any harm to our patients, we shall automatically follow the second principle as well. These two principles are embedded in the ethics of palliative care. Cicely Saunders, Dame Cicely Saunders. We all should read about her career. It is very inspiring. She revolutionized the way in which society cares for the ill, the dying, and the bereaved. She told us to look at the patient and family as one unit and pioneered a fundamental principle of palliative care, the concept of total pain, that encapsulates the physical, emotional, social, and spiritual dimensions of the pain. Until then, the doctors were treating pain as a physical symptom only. The third star of the galaxy is Dr. Balfour Mount. Born in 1939, he's still alive in Canada. He is considered the father of palliative care in North America, like Sir Dr. Raj Gopal is considered father of palliative care in India. He started the first palliative care service in mid-70s in Canada. He coined the term palliative care. He advocated medical aid in dying, but emphatically stated that it is about ending the suffering and not ending the sufferer, as the government policies may suggest. See, if you can read his interview on the internet, it is very delightful and entertaining indeed. So, what is palliative care? This definition may look wordy to you, but each and every line of this definition is very important. There are many definitions put forth by prominent organizations like WHO and National Council of Palliative Care, so on and so forth. All of them may differ in wording, but they all carry the same message as follows. The first line says it is an interdisciplinary medical service. So the medicine, sometimes what happens, it is practiced in silos. People just are talking to their patients in their offices and they are not connected to the rest of the doctors that patient is seeing. So this is interdisciplinary. That means it is interconnected. It is provided at any stage of a serious illness. So it is not only provided at one point in time, it is provided at any stage, and it is not only provided at the end of somebody's life. That is very important, and I'm going to discuss that more further. It improves the quality of life of patients and their families. So this is very important because we are usually focused on patients only. We never think about their families, but this discipline tells us to focus on families as well. How does the palliative care discipline do this work of giving patient comfort and quality of life? It does by anticipating, preventing, and managing health-related suffering. So, and how do you anticipate? Because we have the knowledge in the medical field, we can anticipate certain things. So suppose a patient has ALS, amyotrophic lateral sclerosis. We know that they have dysphagia. They will eventually get dysphagia if they don't have it already at the beginning of the disease, and they are at risk for aspiration pneumonia. So we can delay it by changing their diet or putting a PEG tube, feeding tube in, so on and so forth. And we can prevent the suffering by that way, and we can manage dysphagia by training the caregivers and facilitating patient autonomy, access to information, and choice. Now, patient autonomy is very important in US. Excuse me. What I learned about autonomy in Asian countries is this, that if you tell patient that you have all the right to decide whatever is needed, what you are going to make the decisions, you are the boss, it means isolating the patient from the family. And I will ask Dr. Raj Gopal to talk more about that topic. So patient's autonomy is very important, and access to information and the choice, whether patient wants the treatment or the management of the disease or not. So that is very important. And most importantly, the personhood. When I joined the fellowship, I came to know about new term personhood, and I like it very much. The personhood is not only about a physical body. Yes, we are present in our bodies, but we have a psyche, we have our emotions and thoughts, we are connected to each other with our social connections. And yes, we try to find meaning in our lives, which is the spiritual part of us. So this is what makes a person. So it is not the human body only. So that is very important for a doctor to know. The other important word in this definition is the serious illness. Serious time is spent about talking about the serious illnesses. What is a serious illness? An illness that carries a risk of mortality. Now, there are so many illnesses that can do that. So if patient has a very mild congestive heart failure, or if he have had an acute MI, the ejection fraction is 40%, patient is walking around carrying on with his life. So is that a serious illness? To a certain degree, yeah, we lightly would call it serious illness, but in palliative care medicine, it needs to have something more. It should either negatively impact a person's daily function or quality of life. So patient starts having shortness of breath while walking even to the bathroom, and or a patient is not able to earn money for the family, not go out and meet his or her friends. Yes, the quality of life is affected. The patient should get palliative care at that time. And lastly, but the most important thing is excessively straining the caregivers. So this happens in neurological diseases, and it happens in a lot of other diseases as well in the end, that the caregivers are affected because the patients are not able to do the activities of daily living. So that is a very important concept. This is a conceptual definition that we need to keep it in mind throughout this presentation. So what are the serious illnesses then? So this is a list of serious illnesses, but this is not a complete list. We can add many more diseases to it. Or if you have been practicing for a long time, if you know a patient well and patient has gone downhill due to, say, diabetic complications or autoimmune diseases complication, or nowadays due to the sequelae COVID infection, then they also belong to this list. So you see, the cancer occupies only a small space in this list. The main chunk of the diseases is occupied by the neurological diseases, and dementia tops this list. So we need to know this, that though palliative care is offered, or palliative care was started first for cancer patients mainly, the other diseases also should be included in palliative care, and we'll talk more about it in the next slide. The important thing is, after the cancer, hospices were started for patients with AIDS. Sickle cell anemia is still on the back burner. Even in US, I have not seen that many sickle cell anemia patients being on palliative care. This is a very important slide I'm going to show. I have a laminated card in my pocket, and I share this with the patient's family. This is the trajectory of illnesses. So let us go over this graph. This is the functional status of the patient. This is a normal patient here. Patient gets acute MI and patient dies suddenly, okay? So where there is no need of palliative care, the patient is gone. Let me tell you a story. We were consulted as a palliative care team when a patient, 49-year-old patient, he had cardiac arrest at home and ended up on ventilator because they call 911 here, called the paramedics. He was coded, his heart started, he ends up on ventilator. And then he was found to be brain dead actually. So the family was not ready to accept it because it was so shocking. So they called the palliative care team, and we held talks with the family for 3 days in a row. And we showed them all the x-rays, all the labs. We called the chaplain as well. Chaplain is the spiritual advisor, counselor. And we called social worker, the nurses, the whole interdisciplinary team. And we told the family the truth, the fact that there is no reason that this patient would have meaningful neurological recovery from now on. So finally, the family agreed, and the patient was taken off of the ventilator, and he passed away peacefully right away, actually. So yes, the palliative care team still can help even the patient dies from sudden death. The cancer, we all know, the palliative care team will help a lot, but what happens is sometimes patients and the doctors think that the patient is getting curative chemotherapy. That's the impression. And the palliative care is never consulted. They consult palliative care at this juncture, okay, when patient suddenly starts going downhill. And at that time, the palliative care team is new to the patient. Patient is undergoing a lot of turmoil, and palliative care team has a hard time talking to the patients about the advanced care planning and things like that. It's a very good idea to start palliative care somewhere here or even earlier when a metastatic cancer is diagnosed, okay? The trajectory of cancer is such that for a long time, patients stay functional and they have reasonably good quality of health. And then the chemotherapy starts working very well, causes immunosuppression, causing infections, or there is complications from chemotherapy itself or the cancer itself, and patient starts going downhill. Patients end up in ICU, and they can have a very prolonged ICU stay, unnecessarily so. So the palliative care helps a lot in avoiding this suffering. So beware of this part, that the palliative care should be consulted way back here. Now the organ failure, this is a confusing trajectory, and this will make you look bad actually, because what happens is, say a patient of congestive heart failure comes to the hospital, he's down here at this point in the trough, And the palliative care team is consulted appropriately. We start talking about end of life management of symptoms at home and things like that. And the patient is diuresed, patient does better, and he reaches this point, and the family wonders. All these talks were held. Patient is doing just fine until all these peaks and troughs happen. So I took care of a patient. I took care of him on hospice 1.5 years. He had congestive heart failure. He was 82 years old. And every time he was treated, he was walking around in his house without oxygen. But as soon as he would go downhill, he would become so sick that he would become bedbound. He would be on oxygen, so on and so forth. He had so many admissions, like he had like 6 admissions in like 4 months. So patient and family, both of them chose hospice care. And he did very well, actually. Family was very, very happy that he was on hospice because he did not go to the emergency room or to the hospital during that period. We managed him successfully at home, and the quality of life at home was excellent for this non-cancer illness under palliative care. Initially, it is palliative care. Technically speaking, we had to put him on hospice to get more help because it was in US, and that's how the paperwork is done. But this is very important that in organ failure as well, due to this trajectory, the palliative care should be consulted earlier here somewhere and show this graph to the patient's families that this is what is going to happen. It is not going to be a smooth ride for them, or patient is always at risk for sudden death, patients on dialysis, patients with congestive heart failure with very low ejection fraction, but they do improve. And this part is very confused. A lot of hand holding and education of the family is needed. So please consult palliative care for the non-cancer illnesses here. So the last graph is that of dementia. And this is a very slow and painful progression of the disease. Usually what happens is when dementia is diagnosed in this mild state, people go home and they think that, well, things are well and good. My father is walking around, he has some mild forgetfulness, but it's okay. And this is so vague that the ups and downs are vague, and slowly but steadily they are going downhill. If the primary care physician is aware of palliative care, and if palliative care is consulted here, it makes a lot of difference to the patient with dementia. Because if we start palliative care here, we cannot educate the patient much because their cognition is deeply affected by this time. If you start it here, the patient himself or herself is educated about dementia. When the diagnosis of Alzheimer's dementia, vascular dementia, mixed dementia, all these dementias are frontotemporal dementia, they are made. In frontotemporal dementia, patient is quite young, but still palliative care should be considered because the trajectory of disease is very long and a lot of complications can happen down the road. The main thing, what I want to bring it to your attention is this. I just discussed a case with my friend in Maharashtra. One patient who was 85 years old, he had advanced dementia. He was the father of a physician. He ended up in ICU on the ventilator, had tracheostomy done, and then he passed away after all this torture. If he has had palliative care, this would not have happened, because this is the goal of palliative care, to prevent suffering. So the palliative care should have been consulted on him long time ago. And though the family was in medical field, still they were not aware of all this concept or all this help they could have gotten from palliative care. So that is very important to know. So the trajectory of dementia, palliative care should be considered much more earlier. And I will talk about hospice, when to consider hospice. Please have this trajectory posted somewhere in your offices or have a laminated card with you. What is an interdisciplinary team? In US, it's a village, literally, that they have a nutritionist and physical therapist along with the basic team, physician, nurse, and a social worker. But I would like Dr. Rajgopal to elaborate on this, because he told me that we may not have all these ancillary services available. So most of the work is done by the physician. So physician is always the captain of the team in any case. So that's why it is very important for the physician to get the basic knowledge in palliative care. Now, I have come across people in US and in India, and they are saying that palliative care, oh, isn't it euthanasia or mercy killing? Have assumed it, and I'm talking about doctors, and they never call palliative care for their patients because the patient would think that they have given up. So what are the myths about palliative care? It's only end of life care. That is not the case. End of life care means hospice. So non-hospice palliative care is given to patients at any stage of the chronic serious illness. So bear that in mind. So it is not only end of life care. End of life care is called either hospice or comfort care. Then an attempt to contain medical cost or rationing the care. This is the fear that patients have in their mind. I have come across patients saying that, oh, no, we have money to pay for this chemotherapy or whatever we are doing for my father or mother. So talking about just stopping everything, letting the patient go. And this may not happen in India because the healthcare system is different. Patients pay out of their pockets. But here we are talking about Medicare and other insurances. So the patients think that we are cutting down on cost, which is not the care. I came across a patient, I was on call and I kept getting calls from a nursing home patient that she's very agitated. She has dementia. She used to use with a walker and suddenly she stopped walking. She's very agitated. She's not cooperative. And luckily I had time to go and see her in the nursing home. And I found out that her left leg was actually externally rotated and shortened. So she had a hip fracture, clinically speaking. So I sent her to the emergency room and she was on palliative care at that time. So I sent her to the emergency room and got hip surgery done on her. And she started walking to some degree again. She was not back to her baseline, but family was very happy that it was not ignored and it was just not labeled as agitation of dementia. So that is very important that we do not ration care. We give proper care to each and every patient. Would palliative care hasten death? Never, never. As I told you, the principles, the ethics of medicine, we should always think about them as the Hippocrates has taught us that we should not willfully shorten anybody's life. So we will never do that. Is it doing everything versus giving up? No, it is not like that. It is all together. So patient is getting chemotherapy or whatever treatment he or she is getting for, say, multiple sclerosis, that will be continued. Okay. But all along the journey of this illness, the patient will get palliative care as well. So that is very, very important to know for the doctors mainly, that they should talk to the patient about getting palliative care consultation so that the quality of their lives increase. And this is again the same point I was trying to make, that disease-directed therapies are stopped. This is one of the myths of palliative care. So no, disease-directed therapies are not stopped during palliative care, whether it is cancer or non-cancer illnesses. I have taken care of patients with ALS. They continue to take Riluzole, and that is the medication for ALS. Even if it has a very marginal benefit, they continue to take it until they go on hospice. So what is the difference between palliative care and hospice? And your patients will ask you this. You can consult palliative care anytime in the disease process, and especially if you consult it at the beginning, it will be great. Okay, but the hospice care, it depends on the prognosis. So hospice care is consulted only at the end of the patient's life, that the doctors and the patient's families, they all agree that patient has less than 6 months to live and the patient is put on hospice. All the curative therapies are stopped at that time. So it is palliative care given at the end of life, that is hospice care. Otherwise, throughout the illness, non-hospice palliative care is given. And the palliative care can be provided anywhere. The hospice care may need certain locations such as inpatient hospice unit or at home with a lot of nursing care, because by that time patient is almost bedbound. The basic palliative care training, all the clinicians should have it. When I started working as a hospice care physician, I didn't have the palliative care fellowship yet, but I could still do it. So, but if you want to do specialized hospice care, which includes running patient-controlled analgesia for pain controlled and things like that, or having BiPAP at home. So more care, more higher level of care, then we need trained palliative care physicians. And the similarity, both of them are essentially palliative care. It mitigates symptoms and increases quality of life, and both of them are interdisciplinary care. So what are the benefits of palliative care? A lot of family satisfaction, because families are educated about the disease trajectories, as I just showed you the graph of, and the readmission rate to the hospital is reduced, and the stress on the family goes down considerably. The most important thing is dementia. The ICU utilization is reduced because a patient with advanced dementia should not be in ICU. They do not belong there. They get more confused. They go downhill faster. That's why the advanced care planning is very important in dementia, and we'll talk about it. The physician burnout. This is much talked of in US. I don't know if you talk about it in India, but whenever a palliative care team is called, you have to know that physician is getting overwhelmed by the patient's complicated health issues. And especially during this COVID pandemic, the physicians were burned out uh, really badly. So whenever we used to enter the ICU for a palliative care consult, we used to talk to the ICU team first and listen to their all the complaints that why the family is not listening, how they are not able to convey the message, and so on and so forth. So once you do that, you get a lot of information about the families and patients as well. So it's very important to talk to the physician. And the caregiver burnout, people have written books over it. So this is a big topic. Palliative care team helps the caregivers by arranging for respite care. They identify the caregivers who are unpaid, they are family members. Most of the time they are women. They are not educated in giving patient with complicated illness. They call the palliative care social worker, and they help to mitigate the caregiver burnout. What are the functions of a palliative care physician? So by now you must have understood that communication is at its crux. If patient has a certain kind of complicated disease, say ALS, multiple sclerosis, the other neurological illnesses, strokes, like patients are bedbound from strokes for years together, and they continue to go back and forth. Sometimes they end up in ICU and things like that, and their quality of life is very poor. Nobody sits down and explains it to the family that, look, this is not a good situation. And families feel very guilty about talking about end of life issues, or not taking them to the hospital, so on and so forth. So communication is very important. Then the advanced care planning is very important. We are going to talk about it. Pain and other symptom management. Dr. Rajgopal and I did a webinar on how morphine is important in palliative care. So all the doctors, whether you get palliative care training or not, you should know how to prescribe morphine, and I would highly recommend getting trained in use of opioids. The medical power of attorney. So you have to ask the patient, and this is why palliative care has to be consulted early on in the trajectory of dementia, so that patient can designate a medical power of attorney, a person who can make decisions for the patient himself or herself down the road, when patient will not be able to make his or her own decision. So this is a very important person in patient's life. So and this needs to be discussed again and again, and patients should be encouraged to have this paperwork done at the earliest in any chronic serious illness. Family caregiver supports should be defined, and who is going to do what should be defined. And the last one is reconciliation of medications. This is extremely important because patients can have side effects from a lot of medications, and they can suffer from that. And so many medications have to be stopped. Patients with dementia, they continue to take Aricept and Namenda, Donepezil and Memantine. The medications for dementia, they work only for an year or so. And then after the effect of medications, it wanes off. So you have to make it clear, family understands about that. And you have to do mini mental status exam every 3 months, 6 months, and give an objective report to the family that, look, these medications are not helping and we need to stop them, because the risk, the side effects are greater than the benefits of this medication. So reconciliation of medication is very important. Advanced care planning, this is the most important thing that palliative care doctors do. It is part of basic palliative care. It is not a specialized training at all. Every doctor should know how to do this, and is a core competence for all physicians. It is recommended to start in early adulthood without having any diseases, by the way. So I have done my own advanced care planning. I do not have any chronic illnesses, and I have asked my children to do advanced care planning as well. So in the context of being in the doctor-patient relationship, when do you start talking about advanced care planning? And people think that, oh, if I'm going to start talking about this, patient will think that we are talking about death, we are giving up, we are not going to continue the care. That is not the case. Actually, once this is done, once the discussion is done, patient and family, they feel more educated, more in control, actually. And this is it. You may feel that this is just done at one visit. Not necessarily. This has to be repeated in 2 or 3 visits, as per my own experience in the hospital. In the clinic visit also, you have to bring up the topic over and over again, asking them, did you do that paperwork? Do you have any questions about that? So when do we do it in the clinical setting? When there's diagnosis of a serious illness made, so the list of serious illnesses I told you, when there is progression of disease, so patient with dementia ends up with aspiration pneumonia, or there is functional decline, the patient with multiple sclerosis is now using a wheelchair, there is poor quality of life, patient has bed sores, patient is completely bedbound, patient has limited prognosis, patient has ALS, amyotrophic lateral sclerosis, patient has respiratory failure, limited prognosis. And if palliative care is consulted at that time and not earlier, then yes, by all means, do the advanced care planning first. And transitions in care settings. So if the patient comes to the hospital from home, but from the hospital, patient is not able to go back to home because it's very difficult to take care of the patient. And at least this is the way it happens in US hospitals, that patient go to a nursing home or a group home or inpatient hospice unit. So when these transitions happen, again, discuss the advanced care planning. So what is discussed exactly? What are we going to discuss? So first is patient is getting disease directed therapies. You have to ask the patient, this is the most important patient you are going to ask, that what is the treatment you are getting? Do you know about it? What is it? And what disease you exactly have? What is the extent of your disease? There was a study done on metastatic colon cancer patients. It was found out that 40% of the patients didn't know that they were not getting curative chemotherapy. They thought that whatever treatment they were taking, magically it was just going to wipe off their cancer. And that was not the case. And they were very upset that they were not told details about this. What happens is when the oncologist is talking to the patient may not be all there because they are overwhelmed by the diagnosis. And this needs to be told to the patient again and again. And when patients come to the palliative care clinic, it is discussed it with them, explained it to them in details. And that is a very good thing. And that helps the patient most in doing advanced care planning. So this is done so that patients can refuse treatments if they think that is too much for them, they are not able to handle it. They can refuse the treatment at that point. Starting, maintaining, or withholding or withdrawing therapies, and this happened with COVID pneumonias a lot. I took care of a 50-year-old patient with severe hypoxic respiratory failure with COVID pneumonia. He was on ventilator for 4 weeks. He had hypoxic brain damage, and they called the palliative care consult. We talked about the living will, and everybody thought that he was so young. Nobody ever discussed living will with him or the advanced directives. No advanced care planning was done. And suddenly he was faced with this big crisis in his life, and his life ended. So at that time, a family was struggling with the whole thing because nothing was written on paper and they had to make decisions for the patient. So it is very important to do advanced care planning, especially when it comes to withdrawing therapies. Transitioning to end of life care and hospice, yes, this needs to be done, as I said, in the transitions in care setting. Non-cancer illness, dementia is a looming pandemic as the population of India is aging. Prevalence of dementia will go up. In general, it is stated that it is 10.6%, but it is very frustrating to get a good statistics on dementia in India. And that is what is said in a lot of articles, because there is a very beautiful map of India with all kinds of arrows in each and every state, talking about the prevalence in those states, and it ranges from 0.8% to 10%. So it is very heterogeneous. It is, and again, it depends on what kind of tool do you use to get the information. So what kind of mini mental status exam or Montreal cognitive test you use, and that will change the statistics as well. So this is a very difficult topic, and since we are talking to the president of IMA Maharashtra, they may start a study all across Maharashtra to gauge the depth of dementia in Maharashtra. So we can talk about that. So this is a very magnificent movie, and this used to be a play, King Lear. And if you haven't seen this movie, it's your homework to see this. This is Sir Laurence Olivier, this actor. And King Lear has dementia, as you must know. This was the play written by Shakespeare. He is asking, who is it that can tell me who I am? We are all afraid to reach this point in our life, and we only hope we are surrounded by good, compassionate people. Let me start this audio. This is the testimonial by a patient's son who took care of her for several years.
I never thought I would have to make any difficult decisions for my mother. She has been healthy all her life. We are two siblings. We never talked about the possibility of any illnesses at the end of her life. Talking about her death did not suit any occasion when she was still alive. When she was diagnosed with dementia, we did some reading on our own. We discussed with her doctors, especially her neurologist, but we were not prepared to deal with the last few years and especially the last few months of her life engulfed by dementia. In the initial stages of dementia, it was easier to take care of her. She was mostly forgetful, was not able to take care of her financial affairs. She stopped cooking. Later, hygiene became an issue. Then she started falling. We had to make the whole house secured for her, like one would take it for a child. The worst part was she became incontinent of bladder and bowel. Keeping our house clean became a never-ending task for us because she was still able to walk around in the house. I talked to a palliative care doctor from US because palliative care was not available in our town and it is still not available here. The palliative care doctor suggested two very important things. One is how to control her agitation. Secondly, if all the siblings agree, treat her at home only and not to admit her in a hospital. That gave us a plan of action, an orientation to the end of life issues. One day, she had a fever. Her doctor gave her antibiotics at home. She slowly declined. It gave us time to call our close family. She passed away peacefully when her children were around her, in her own house, in her own bed. When we look back, we are thankful that we had the courage not to hospitalize her. I wish that she had palliative care services from the very beginning. It would have helped us understand her disease better, plan ahead of time, and reduce the stress on our families. Thank you.
The common symptoms in dementia, as you must have heard, agitation, and rest of the list in this list, all the symptoms, they may cause agitation as well. So if you are on call for, even in adult medicine, you get a lot of calls on agitated patients. You need to know the patient, first thing. And secondly, you need to ask all these questions. If you help the patient with agitation, the family will be very, very grateful. All these symptoms can be treated effectively with medications and some non-pharmacological methods as well. We need to treat it and not dismiss it as just because patient has dementia and that people may tend to do that. So that is very important. So what do we do in dementia? Do we do specifically anything different in advanced care planning? Yes, as I told you, we have to document patients' wishes. What are the wishes about what? It is about end of life care, or suppose down the road in dementia, patient starts having dysphagia, difficulty swallowing. Does he or she want a feeding tube placed? And this is a big deal in our hospitals. We have spent so much time on it. We have to call the GI consult. The GI consultant will say, patient has advanced dementia, I'm not going to put the tube in. Patient's family says, we do not have anything in writing, whether patient wanted it or not. We do not want our loved one hungry and things like that. So all these things come into play if patient has not documented his or her wishes. So it is our duty to bring it to the attention of the patient and family that these things can happen down the road and this should be discussed. And this may not happen just on day one that you tell the patient to do the paperwork and it is done. They have to think about it, and they have a lot of time in dementia. Medical power of attorney, as I talked about it, financial affairs, it's a no-brainer. And the trajectory of dementia, I told you already. The unnecessary treatments and procedures, I already told about the story of a very advanced dementia patient who ends up on ventilator. That should be avoided at any cost. And the most important thing is to keep patient comfortable, especially at the end of life and throughout the illness, actually, and by avoiding the unnecessary treatments. So what are the unnecessary interventions? The feeding tubes, hospital admissions, bladder catheterizations. I have had patients who had Foley catheters. They went home with that because they were incontinent of urine and they have pulled the catheter, causing severe traumatic hematuria. Do not do that. Parenteral therapies, when patients are declining so fast, they are not eating or drinking, patient's family demand IV fluids. And at that time, you really need to educate that this is going to prolong their misery. It may build a fluid in their system. It may cause shortness of breath. It may not help them in the long run. So this needs to be avoided. Labs, X-rays, they are of no use when patient has advanced dementia. So the lighter side of life, this must be kept in mind, that discussing advanced care planning or the advanced directives is a very heavy topic, and it can take a toll on the physician or the family as well. So when you enter the patient's room, make the atmosphere a little bit light by telling a joke. This is the joke I always tell, that Bob Hope, this is the very well-known American comedian. So Bob Hope was asked that after your death, would you like to be cremated or buried? And he scratched his head for a second and he said, surprise me. And this puts smile on everybody's face and it breaks the ice. It's an icebreaker basically. And then you start talking about end of life issues. These are very important, at least in US. We use a scale called FAST, Functional Assessment Staging Tool. If patient has reached this stage 7, patient has started behaving like a child. And when you are taking care of a child, that child is growing to be a person. And now this patient is going downhill. All the layers of the personality, the psychological, social, spiritual, they're falling off. And this is a very heart-wrenching state. This is what the functional assessment staging tool looks like. So if you reach at the end of this scale after 6E, and actually if the patient is at 6E, moderately severe dementia, and if patient has concomitant illness, please consider hospice for this patient because it helps the family a lot. So below 7, once they reach 7 and below that, they are becoming more and more dependent on people, and they are becoming bed bound. They stop recognizing their family. They stop smiling. And this is very heart-wrenching. You do not want to see anybody in this stage. And that's why if patient gets some kind of acute illness or say acute MI at stage 6A, please do not try to treat it aggressively. And this is the point I really want to make. Do not take them to the cath lab and put stents in them, because Mother Nature is being kind to them. Instead of reaching this miserable stage, the Mother Nature is closing the chapter at that time. So you need to help patient be comfortable at that time. And to look at the whole big picture and not just the heart. Okay, so this is very important. This fast scale also, we keep it in our pocket as a laminated card to show it to the family. Now I have created this website for patients with dementia. We can talk about it. So I have talked a lot. I have given a lot of information, but knowing is not enough, and we must apply this in our day-to-day practice. And willing is not enough. So from the dignitaries, from the people at a higher level who have power to do something, I hope they can help us spread the word and get things done in the area of statistics of dementia, the basic palliative care in dementia and other non-cancer illnesses, and getting fellowships in the universities, and training the volunteers. So this person, Gut, Goeth is spelled as Gut, he's the German Ramdas Swami, the Kelyane hote ahere, Adi kelechi pahije. That is what is written exactly here. Palliative care training. Pallium India has training on, and it's available on the website, the information. And the Indian Association of Palliative Care, they also have certificate courses in palliative care. And Dr. Rajgopal himself is a role model for us. He has written a very good book. It's a excellent readable material. I have it. It is available on Amazon, at least in US. All the doctors must read it, how he became a palliative care doctor and how he still practices in his 70s. He teaches, he preaches, and practices palliative care. So he will talk more about it. I want to end my presentation by this last slide with Shakespeare's sentence in this play, again, King Lear. One of the courtiers of King Lear asks him, "Sir, let me kiss thy hand." And King Lear says, "My hand smells of mortality. Let me wash them." So the only Shakespeare can write like that. So all of us, we all smell of mortality, and only if we support palliative care, we will be able to change this smell of mortality to perfume. So thank you very much for listening to my long talk.
And thank you so much for delivering the talk. It was very elaborated and very clean and very touching to the heart. The talk was so good. And now I go towards our honorable speaker. Definitely, sir doesn't require any introduction. From Jammu Kashmir to Kanyakumari, everyone knows sir. But still, I have to do the formality. Sir is a Padma Shri. Sir was nominated for Nobel Peace Prize also. Sir is the director of Trivandrum Institute of Palliative Science, which is collaborating with WHO and Pallium India. So definitely, we now want the greatest guidance from the greatest person. Sir, the dice is all yours. Please do the honors.
Thank you, Bhagyashree, for that discussion about palliative care and non-cancer illness. It's possible that, considering that palliative care is available to only a small number of people in India, and even smaller number of people with non-cancer illnesses, some of the advices that you gave could well have been totally contrary to the practice in India. For example, in Western European countries, UK, Belgium, France, Germany, Netherlands, everywhere, and in USA, if somebody is on a life support system like ventilator, and then the disease is considered not salvageable, in futility of treatment, we have data that about 70% of people are then taken off the life support system and allowed a natural death. Whereas in India, for the small percentage of people who do go on life support systems, it's only 10% of people who get the support system stopped. 90% of people are kept on a ventilator or other life support systems indefinitely. I have a friend in Kerala who got COVID. He was a hospital owner. He was kept on a ventilator for 37 days. And then ECMO was started, extracorporeal membrane oxygenator was started. And then that continued for another 30 days. And the whole hospital was lost to the survivor, his wife, who's a doctor. And our association had to take a collection to pay off part of the hospital bill. Now, the money is one thing, but beyond that, it was also, of those 67 days, much of it was agonizing suffering for him. And this comes out of one, lack of availability of palliative care. We don't know what else to do.
Yes.
Secondly, possibly, especially for the younger generation of doctors, a mistaken impression about what their duty is. What is our duty of care as doctors? Please, ladies and gentlemen, take a moment to think. How will you define our duty of care to the patient?
Yes.
Is it to diagnose and treat diseases? Well, I'll share my screen and start with the official definition of duty of care in India. It is to mitigate suffering. This is from the Bioethics Unit of Indian Council of Medical Research. The duty of care of the doctor is to mitigate suffering. It is to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. We do not have a duty to prolong the heartbeat indefinitely in incurable, unsalvageable situations. And a Supreme Court judgment of 2018 reiterates that. Our duty is to mitigate suffering. My friend shouldn't have had that suffering for more than 30 days till he lost consciousness. Now, the topic was non-cancer illness. And please note that according to the data available to us, only about 20% of all palliative care need is for cancer. Globally, not in India perhaps, but globally, the bulk is HIV. But globally, dementia accounts for 6% of all the palliative care needs. Now, palliative care is 55 years old globally, and in India, certainly more than 35 years old. Since the first hospice, Shanti Avedana Sadan, came to Mumbai created by Dr. Lucido D'Souza in 1987, at a time when I had not even heard the word palliative care. But between then, over these 35 years, growth of palliative care has been very slow, which means our risk of dying in agony is very high. Sorry to bring in the bad news. This is why we have to do something about it. It's not about them. It's about us.
Yes.
Human mortality is 100%. No one escapes. Only 10% of us can have a sudden death. 90% of us goes through a prolonged illness and suffering before we go. And that is why we need palliative care. In low and middle income countries, of the 51 million people who are in health-related suffering, 7 to 10 million are in India, unrelieved suffering. And we leave behind vulnerable people. For healthcare is not available to people at the extremes of age. Women are marginalized. People living with disabilities live within 4 walls forever, except to go to the hospital. Those with a different sexual orientation, prisoners, tribal people, culturally isolated and geographically isolated. Our healthcare leaves them all behind. And in addition to that omission, our error of commission is an unbelievable more than 4% of the population subject to catastrophic health expenditure. India is one of the 12 countries where the destruction of people by catastrophic health expenditure is worst by World Bank data. And friends, I'm sorry to paint this dismal picture, but this is all truth. India is a country where more than 29,000 people kill themselves for health-related suffering. This is on the National Crime Records Bureau. Only the reported successful suicides get into the data. We don't have data for the people who attempt and fail. And this is why Dr. Sankhamitra, an oncologist of Bengali origin, who does charity work in Northeast. He works in Australia, makes money to spend in Northeast of India. He says in India, the poor die in misery of neglect, with no palliative care, no pain relief. The middle class die in misery of ignorance. Even if palliative care is available, they don't know about it. Then the rich die in misery on ventilators. No one gets a pain-free and dignified death. And many, many thanks, Dr. Bhagyashree and colleagues, for trying to change this, to bring some compassion into healthcare. Our National Cancer Grid, many of you must be members. More than 350 cancer treating hospitals in India are members. They have given a clear recommendation. The conglomerate of cancer organizations in the country have given a recommendation: do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. Friends, is that what happens? Anybody with any money in the pocket, even with advanced metastatic cancer, dies on ventilators. There is no justification for this, neither ethically nor legally, because of the Supreme Court's verdict. And Bhagya, I'll skip over this. Bhagya already made this point, that palliative care is not only to be given after curative care is given, but to go hand in hand with the curative treatment. And when eventually death comes, it continues as support for the bereaved families. This is what we actually practice. I'm not just quoting theory. But clearly, it is not only for the dying, as Bhagyashree very clearly mentioned, it's for any serious health-related suffering, when necessary, along with treatment of the disease. Let me give you an example. Suppose somebody with an advanced COPD, chronic obstructive pulmonary disease, comes to you, gasping for breath, unable to lie down. It's cruel to isolate him, take him away from the family and isolate him, to die in an ICU. We should try oxygen for about 10 minutes. Equilibration between inspired air and arterial blood takes only 7 minutes at most. In 10 minutes, we will know if it gives him benefit. I'm saying only what I practice. I'm saying only what I feel I deserve. In those 10 minutes, I won't be looking at the pulse oximeter. I'll be asking the person, do you feel any better? If not, I'll take the oxygen away. You all know how people keep pulling the mask away. I would use corticosteroids to reduce the edema, to ease the breathing, and surprise. Morphine now has become the drug of choice. American Thoracic Society, including and other organizations in their guidelines, have said morphine is an essential medicine in terminal breathlessness in people with chronic obstructive pulmonary disease. And my own professor, who died 3 weeks back, was started on morphine about 2 weeks before she died. She thereafter could manage without morphine because the breathing becomes easier and quieter. We are not talking about huge doses. We are talking about small doses. And friends, India does not have a law covering end-of-life care. Therefore, the Supreme Court judgment of 2018 holds valid. In the absence of law, a Supreme Court judgment holds valid. it is permissible to withhold or withdraw artificial life support at the end of life when in the face of futility of treatment, which is to be decided by the treating doctors, more than 2 of them. Now, I was talking about breathlessness. Bhagya was also talking about pain, and we were talking about symptoms. But the suffering is not only physical, it's also social, emotional, and spiritual. And in our palliative care center, the doctor and nurse will be mostly taking care of the physical symptoms, though everybody looks after everything. But there are trained medico-social counselors, psychiatric and medical social workers trained to do this, who look after the other domains of care, psychosocial, spiritual domains of care. But that means going deeper. Look at this iceberg. Only 1/8 of it is visible, as you have learned in primary school. That is what we usually see. You need to dive deep into these waters to identify emotional problems, relationship issues, sexuality issues, spiritual issues. Ordinarily, we do not care for them, but the difference we can make to human lives when we do get into the depth is enormous. I am not saying that right from the beginning, we'll be able to go deep down and get there, but as our experience improves and as we learn more, this becomes possible. About social issues, let me tell you about Geeta. Geeta is not her real name. A single parent. Do you see something that looks like a hen hoop? This was where she actually lived. She was a juvenile diabetic, single parent. She had been advised above knee amputation. She was blind for 4 years when we saw her. And they starved through a weekend in this chicken hoop. On the Sunday, her 12-year-old son told her, "Mom, I cannot bear this hunger anymore. Let us kill ourselves." She persuaded the boy to hang in there for another day, went into the hospital and declared that I cannot go home. I'm not in any condition to go home. And a kind doctor admitted her. Before we saw her, she had spent 3 months in that hospital. This was in a community health center. And one sweeper of the hospital, ladies and gentlemen, imagine, it was not a well-paid doctor, it was not a nurse, it was a lowest paid employee who took it on herself to cook for the mother and son and bring food every morning so that they could have 3 meals a day. Is this palliative care? She needs disease-specific treatment. I'll come to that. We got engaged because nobody else was there to look after her. What happened was that we facilitated our social worker and our volunteers arranged to pay for a paid caregiver so she could have a retinal surgery in the government hospital. And after 4 years, she saw her son again. She did not lose her leg. Expert treatment for the diabetologist advice preserved her leg. Actually, this picture, Bhagya, thank you for showing me the cover of my book. This picture appears there. That's of this mother and child who still live in Trivandrum. And when you visit, I'll take you to meet them. They have a roof over their head now. Now, this is what is possible when we work with the community. As a doctor, I wouldn't have the power to do all this. But then let us explain how we do this. One thing we have to realize that in the country that Bhagyashree works in, primary, secondary, and tertiary care are reasonably good, and palliative care becomes necessary only to fill that need of physical and psychosocial spiritual support for a minority of patients. Consider our country. Primary, secondary, and tertiary care of quality reaches a tiny minority of people. We shouldn't have had to treat Geeta to take over her management. But the fact remains that when we face the problems, we are confronted with this huge unmet need. And somehow we feel the need to fill it. And this will become possible when we dare to look at it. And friends, here is something that for all of us to do. Okay, we may start a palliative care unit in your city someday, but how can they take care of all the suffering? The World Health Assembly, that's the decision-making body of World Health Organization, in 2014 asked all member countries to integrate palliative care into all healthcare at all levels, primary, secondary, and tertiary, across the continuum of care. That means everybody that I see before me, Dr. Nagina, Dr. Khanna, Dr. Rajiv, Dr. Shweta, everybody is asked to integrate principles of palliative care into their routine management. As you treat every patient, you treat the pain. If they look anxious, you learn to lay a hand on the hand and say, you look anxious, I am going to look after you. You may be very busy, you may not have time to do all that we did for Geeta, but those things mean that when you treat pain and symptoms, and give the little bit of support that you can with our communication, you are already integrating palliative care into your healthcare. And this is necessary across the continuum of care, from the beginning of the suffering to the end. I have here an image for you to see. A palliative care unit, like our unit, looks after a minority of patients. But when healthcare providers all take on part of the role in their own settings, we can reach the huge number. And for all of this, partnership by the community plays a major role. We were able to do all that for Geeta because we engage with volunteers, lay people who are trained and are willing to support us if we open the healthcare door. But of course, for integration at the macroscopic level, the national policy can be changed. And in fact, in India, the national health policy of 2017 includes palliative care at the level of the primary care. When one hospital includes palliative care in every treatment, that's a meso level. And when any one of you take on the job of treating, including palliative care in your routine practice, that is the micro level. And as I said, in national policy, 50,000 family wellness centers now have an opportunity to learn a bit of palliative care. 2 hospitals in our country are already pain-free hospitals. Kachar Cancer Center in Silchar, Assam, and the Cancer Research Institute in Dehradun in Uttarakhand. They have every doctor and every nurse trained in pain management, and every patient asked, do you have pain? And treated. And of course, every one of us is a micro element for the integration. Now, if you think that this is all empty dreams, no. India created a national program for palliative care in 2012. In 2014, the NDPS Amendment Act was published so that access to morphine is easier. The National Health Policy of 2017, as I said, includes palliative care. And friends, from 2019, every MBBS student has palliative care included in the curriculum. Implementation of this was delayed by 2 years because of the COVID, but it's happening now. And nursing curriculum since 2020. So friends, it's safer tomorrow to have a serious illness, which unfortunately every life has to face. I'm sure there'll be questions. I'm glad I finished early enough to facilitate some questions and answers. Thank you everybody for listening to me patiently. And thank you, Bhagishri, and colleagues for making this possible.
Thank you, Dr. Rajgopal. It was very, very informative, very nice.
Enjoying these talks on palliative care, which is a very important subject, but very less spoken about. And today is a masterclass session. This field, as I mentioned earlier, is not spoken much about, but is very, very relevant in today's clinical era. And, it is the need of the hour. And with a expert speaker like you, we would definitely want all our members in Mumbai and Chembur especially to be enlightened on this aspect of cancer care, which improves the quality of life of both the patient and the family members without adding extra costs, which is the usual norm in cancer care, especially when surgery is involved or radiochemotherapy.
Yes.
Indeed.